Good morning, everybody. Welcome to the Perfecting Peds show with Jena Quinn. I'm so excited to be here, and we're talking about something near and dear to so many of us that had ear problems growing up. And I talked about that last time, but tubes. I did not get tubes, Jena, and you and I are talking about that. One of your daughters had tubes, and so just wanted to kind of jump in with your thoughts overall. I know it changes a lot, which is very interesting about how we're applying antibiotics and what we're doing next. And then you also
Yeah,
talked about, the other piece was antibiotics in general. Like how are we using antibiotics? And if this antibiotic doesn't work and we need to switch, how do we utilize, appropriate antimicrobial stewardship to make the right decision? So I'm going to pass it off to our star, Jena Quinn.
yeah. Thank you, Kev. It's always a pleasure. Um, so interestingly enough, my middle daughter went through it and has tubes, and they have been a lifesaver. Which is probably, honestly, I probably know more from just personal experience than I do, working in the peds world. And then my third daughter, Avery, is like in the midst of it. So she 100% needs tubes, and really I always like want to empower parents to know like how many ear infections and how many, like, what's the time span when it really is beneficial for the patient, or the child to get evaluated, because like we'll go into, it's been life changing, and it minimizes drug resistance and a slew of adverse drug reactions. So my third child right now, so she is the living proof of drug resistance and just treatment in general. So the past 6 weeks she was treated with amoxicillin, which all these always are like second bacterial infections superimposed after a virus, which every kid in the US is seeing: rhino, entero, RSV, COVID, flu. I mean, I think this has definitely been the worst winter. And it kind of like has run into this like long cluster, because RSV started in the middle of the summer. Like the viruses are confused too. um, so yeah, like I've never, as a pharmacist, had to do Synergist, which is the kind of like the prophylaxis to RSV in the middle of the summer. And we actually got insurance approval to start doing it in our NICU babies in the middle of the summer, which never in my 12 years has that happened. So I'm hoping and praying that in April it starts to like go back to the regular viral seasons, but who knows? But that being said, my 9-month-old had treated with the mox. It resolved for like a week and a half. Then it came back to the ear infection came back again. I can just tell by how she sleeps, because like she'll be like up all night. She's not fussy, so she's like an angelic third child, but she is up, and she does get she gets a fever. So my middle child would spike to like 104. Luckily she only gets to like 102, 101, 102. So then I took her in, we did augmentin, we did the 10 days of that, which we can also discuss the new duration of antibiotics. And then that she got nasty GI effects, which, like up to 35% of people that you're going to prescribe augmentin are going to get these GI effects. And the most important things as a pharmacist to know is if you're doing that high dose augmentin in kids, you're really trying to target strep pneumo and H flu resistance. And when you do that, it's really important to do the 600 per 5 clavulanate. There are so many different concentrations, but really where that side effect or the ADR of massive diarrhea is from that clavulanate. So because of that, you always want to be cognizant of the concentrations of augmentin, because if you accidentally are doing, high dose for that strep pneumo H flu resistance, you're going to cause, and you do it with an incorrect concentration, you're going to cause a lot of more GI side effects than, my little 9-month-old already had on the high dose or the concentrated one.
Yeah.
So then I had in the middle, after she got another virus. So it's just been like virus after virus. And then literally 3 days ago, I took her in again. She has, after it cleared up, she has another ear infection, and all of them have been double ear infections, bulging red. And so, some things they say that you can do to minimize the risk of ear infections are breastfeed and try to not use the binky as much. And I do both. They said like a high use of pacifier use can actually lead to that. So we do both, but obviously sometimes that's not enough. And now that she had one prior. So really when parents should know, because of like urgent cares, everybody goes to different places, right? So your primary care doc may not have that information available, but what's really most important is that that as a parent, if your child has 3 infections in the span of 6 months or 4 infections in the span of a year, they qualify for ear tubes. Perfect. So, and actually it was cool because I showed Kev an actual video of my middle child's ear tubes, which were so cool. But what those tubes do, and why, a little bit about it, is that, your child will get a benzo beforehand. So, you obviously that's not you don't want your child to have it, but they get them nice and relaxed before surgery. My daughter loved the midazolam. She was having a party on it. She was nice and relaxed, and then I was teasing her putting on dance music, so she loved it. She reminded me of my husband in college because they look identical. And then they go in and they do gas. So, they're down and out. And she actually, like, post anesthesia did great. I think she was like a rare unicorn. Some kids do wake up and they're like angry and like violent and having temper tantrums, but she thought the whole thing was awesome. But in the procedure itself is about 10 minutes. So you go in, they give you, your child a sedative, just really for that, because there's such high anxiety of a nurse and a doctor taking them back to the OR. So she was like nice and relaxed. Then they gave them gas in there. And again, it was on and off, and she came out within 10 minutes and it was done. That, to me, compared to how much an ear infection takes out of children alone, was completely worth it. Like, and obviously every child's massively different. Like, she wouldn't sleep. She wouldn't eat. She would get temperatures to 104. She was the one child that was resistant to Amox, Augment, and Ceftonir. And then I actually had to take her to the hospital to do 3 days of ceftriaxone. The thing too, also to know as a parent, is when you call ENT, once they qualify for those ear tubes, it takes like a couple months to get in. And that's the worst part, right? So with Avery, I have an appointment for March, but I can't get, so right now I'm just giving her antibiotic after antibiotic after antibiotic, which is awful. So as I said, like, every antibiotic increases your risk of having antibiotic resistance in the future. And also, so you want to stay most narrow, but also it is nasty to your gut flora. So I know, as I spoke before, I always pair that with the probiotic. But with these ear tubes being in my middle daughter, what happens is it basically decreases the severity of the acuity when they get ear infections. So she still gets ear infections, but what happens is it's very gross. You can actually see the pus and the drainage come out of her ears. So, because really what gets the kids so sick is having that accumulation of the pus and all the bacteria just sitting there. But when they don't like have that, it's just going to come out and they're not going to get as sick. So their fevers aren't going to spike as high. Like, she still gets ear infections, but her fevers don't spike as high, and she doesn't get as punky. She's eating still. And there's no pain, right? Because really the pain is the pressure. sometimes you'll very rarely hear a kid complain of pain, and sometimes that's like when the pus and everything's kind of just like going through the tube,
Yes.
or gets like caught for a second. She's only complained of it once, but really it's to alleviate pain, the severity of the illness, and use of antibiotics. So I think I was so hesitant going into it because I'm like, oh, I don't want my kid to have surgery. But that compared to a kid who gets so ill and it takes so much out of them.
Yeah.
The thing too is you'll no longer need oral antibiotics to treat these infections. And if you ever have a provider offer you an oral antibiotic with tubes, just nicely decline, because it's happened to me a couple times. All you need to do is put ciprofloxacin or ofloxacin drops right in the ear. It's
Mhm.
4 to 5 drops 2 times a day for 10 days, and it will clear up. The other thing, and if it doesn't, you got to culture that nasty stuff coming out of the ear.
Yes.
The other thing too, I just real quickly wanted to touch base on was the new updated. Now, there's no updated guidelines, but newer literature for everything across the board is really trying to push for a shorter duration of antibiotics than we had thought through previously. So really looking into where the durations were coming from for Lexicomp. It looks like now we're using more of an age and severity.
Mhm.
So if you have anyone less than 2 years old with a severe infection, you're going to still do the 10 days.
Okay.
But if you have someone between the 2 and 5 years of age, they're saying 7 days is sufficient. And then anyone greater than 5 days is
I
sufficient.
just
And then some will scale it by severity and don't even include the age. So some will say mild or moderate, 5 to 7 days is sufficient, and severe, 7 to 10 days. So it's not set in stone, but what it's showing us is that, traditionally when we thought these, I mean, and the same goes for community acquired pneumonia, but we're evolving into shorter durations for a lot of antibiotics. So I just wanted to stress that that's a change in practice recently that I'm still getting comfortable with. And again, just navigating drug shortages, it's great to know that if your patient qualifies, you can actually shorten up that duration, and then they need less antibiotic, which is great for everyone, especially for resistance, but not only resistance, compliance, and also drug shortages. So I
awesome.
do want to note that if you have someone that's you're suspecting is not going to be compliant at all, and it's not a recurrent resistant treatment, you can do 1 dose of ceftriaxone if you're in an urgent care setting. And I am the mom who has actually done that to my middle child because she spits suspension back in my face. And it was kind of a mean mom to do an IM dose of ceftriaxone, but I knew there was no way I was getting that in her at that age, that age around like 19 months to 2.5 years. Um,
Simple, quick, one dose. I mean, I think Jenna, like the stuff, just to recap that what you went over, because we covered a lot in 13 minutes.
yeah,
Everything from like looking at different antibiotics that can be utilized, looking at the augmentin doses and specifically the clavulanate dose on how that impacts the GI. Next time we'll talk about the probiotics that Jenna likes to choose and some of the other complementary therapies in order to avoid antibiotics altogether. The one thing I'd love for you to talk about in our last just minute or so is pros and cons of tubes. So like when you were doing the assessment of putting tubes in and you talked about, I'll run these ones off. The pros that you really mentioned was, decreased pain and issues there, decreased antibiotics overall, and just overall stress. And any other things, Jenna, that you're saying, like, here's the main like hitters when it comes to putting tubes in?
yeah, like decreased pain, decreased antibiotic resistance, but honestly, like increased quality of life for my kiddo, because we would go like 2 or 3 days and she was lethargic, not eating, temperatures of 104. I think she's even gotten up to 105. Like she would get so sick. And of course, the risk of going under general anesthesia and a surgery, I don't want to minimize that either. But for me, and we had an awesome ENT doc, it was just like a no-brainer, because since then she's needed the drop so many times that I just keep thinking probably like 5 or 6. She had her procedure a year ago, but I keep thinking like, oh my God, like she wouldn't have been able to go to school. She wouldn't have been able to we can we can really blow through and resume our normal life, which we couldn't before.
Amazing. Next time, we will cover some complementary therapies and some more on the tympanic membrane and just the overall inflammatory process there so that you guys can kind of dive into that. Thank you so much for joining. And Jena, another wonderful episode.
Thank
To be able
you.
to find Jena, head over to her pediatrics channel, Perfecting Peds in RPH Ally, and join the channel and grab more information. Jena always at the end of our episodes puts a little nugget in there for you to kind of encapsulate or summarize kind of what we talked about and give you a little bit more detail. So go ahead and check that out. All right. We'll talk to you guys soon.
Take care.